interesting demonstration today. Let's start with room 1. Can we have the history of our first patient?
Mr. TPT, a 75-year-old gentleman with underlying COPD and hypertension, and a history of cholecystectomy with ascending cholangitis and multiple CBD stones. CBD stones were cleared, but subhilar strictures were noted. He has had multiple stent exchanges since, and the last ERCP in December 2017, 3 plastic stents, 10 French each, were inserted. We will be inserting fully covered metal stents today. Over to you.
Over to you, Professor Cafes.
The live workshop for today. So very nice to be back with day 2. Do you have the endoscopic and the radiology images?
No, not yet.
So we put the scope down on this patient and we removed the 3 plastic stents. And then we performed a cholangiogram, which we want to show you. Can you see the cholangiogram now?
We have endoscopic view and cholangiogram view.
Okay, so can we screen? So we've got the balloon occlusion. I always find it very useful in such cases. And I'll just bring the balloon down a little bit further and stop screening. And you can see just at the entry point of the right hepatic duct, there's a small indent, probably some scar tissue where the main stricture was. At the moment though, it doesn't appear to be a functional stricture anymore. So I think the 10 French stents over the last few months have done a very good job in dilating this stricture. In fact, the balloon, we've passed the balloon across both the left and the right hepatic ducts and trawled it. And at 12 millimeters, the balloon comes through with virtually no resistance. So my feeling is that this patient has responded very well to multiple plastic stents. And I'm not really convinced that they need to have a metal stent today. The only question in my mind is that whether we've had adequate time with 10 French stents or dilatation. Because as you know, in these benign biliary strictures, if you dilate, the immediate response is as good as multiple plastic stents, but the recurrence rate is higher. So there's a theory or an idea that you need a prolonged period of time with the dilatation, whether it's with plastic or metal, to achieve better long-term results. But my feeling is he's not got a functional stricture anymore, and that maybe we should probably just trawl and clear out any debris or sludge and leave it be. And if it were to recur, then we can deal with it at that point. But I'd be interested in people's ideas or feelings about benign strictures and how long we should stent them for and so forth.
I think that's open question, isn't it, Arthur? But I'd like to ask how long from the time the patient had symptoms or signs until the stents were placed? Because if the stricture were left for a longer period of time, then they are less amenable to dilatation with multiple stenting. How long was the history before the patient came to see us?
The cholecystectomy was done early last year. And the patient presented with cholangitis quite soon after that, and had multiple ERCP where the stones were cleared. And we noted the stricture, and since then we have been increasing the number of stents that we insert for the patient. So I would say it was pretty early.
So that this sort of patients would normally respond well to this sort of stent placement. Would you agree, Maru?
I think the stricture most likely due to the ischemic stricture, and of course the multiple biliary plastic stents dilate the stricture. But normally what I will do in my setting, I insert a expandable metal stent as we discussed yesterday. That will be my preferred way of treating benign stricture.
Yeah. So if you can see, if you can screen for me, you can see the balloon is coming across the stricture and going back up inflated. that's a sure sign that the stricture does not need further dilatation today. The only question is about longevity. I mean, putting in more stents, leaving it for an additional few months. I think this is very patent. That's a 12 millimetre balloon going up and down across the stricture. I don't think we need to do anything. Sorry?
It looks like we are not going to be able to see the cafe stand today.
No,
we have
no.
the man himself here today, but unfortunately we couldn't see it.
Yeah, I mean, it's close to the Highland, but still doable with the metal stent. And of course, yesterday I spoke about the traditional type of stents that sit at the bottom part of the bile duct into the duodenum. Well, these post-cholecystectomy and liver transplant stents really lend themselves to the intraductal stents, like the stent that I developed with Taewong. And it's much less migration. We had 40 stents. We had one migrate proximally, which was easy to remove because of the string. Whereas the traditional stents for these strictures, which are quite high up, have a migration rate of about 30%. So it's, you know, you can choose the stent that's ideal for the stricture today.
Professor Cafe, so for this patient, we are not going to reinsert any stent. How do you recommend we monitor them?
Look, it's pretty simple. Liver tests are probably the best way, and clinically, if the patient should be educated in regards to cholangitis and jaundice and so forth, and you tell them, look, you should be fine, but there's a maybe 20% chance of recurrence. So if your regular liver tests go up, if you develop cholangitis or jaundice, dark urine and so forth, let me know and get them to come back straight away. And if they were to recur, then I would probably go in immediately with the metal stent and aim to leave it there for around 5 to 6 months. That would be my target treatment time. And usually that does the trick. And in regards to a discussion yesterday about cost effectiveness, the point is, how expensive is an ERCP? And in Australia, an ERCP is very expensive. And so the cost of a metal stent is a lot less than having to do one extra ERCP. So it's very easy to achieve cost effectiveness using metal over plastic. And certainly we showed cost effectiveness in the liver transplant population with the anastomotic strictures. So I definitely think metal stents now have replaced plastic in many circumstances. Not all, but many. I think we're finished now.
Yes.
We're done. So we deflate.
So I think that's all from room 1. Probably room 3 is already ready with Professor Nantali with a case.
Yes, we shall have the history of the patient first. Can we just have the history for room 3?
Madam SS, a 71-year-old lady with underlying hypertension, had an OGDS showing subepithelial lesions at the fundus of the stomach. EUS showed heterogeneous lesions arising from muscularis propria about 2 cm in diameter. We'll be performing the EUS FNA today.
Over to you, Professor Nantali.
Blind spot of the scope.
Endoscopic view, please.
Air. It's on. Yeah. Yeah.
Professor Natalie, you're on air now.
Is it this? This? I get. Yeah, I think this is it.
I'm sorry, Professor Nantali. Apparently room 2 is also ready. We shall switch to room 2 first before we come back to you. Can we have the history of the patient in room 2? Let's move on to room 2 first. Please proceed.
Mr. YSC, a 60-year-old gentleman with pancreatic adenocarcinoma and liver metastasis and nodal metastasis as well, had a metal stent inserted at the end of 2016. However, had several episodes of fever and deranged liver profiles, and an ERCP in January 2018 showed fractured metal stent. A plastic stent was inserted. We will be performing the ERCP and then we'll proceed accordingly after that.
Professor Ponchon, you're on air now.
Okay. So good morning, everybody. So it's my pleasure to be here again. And well, just in front of Papilla, I have a chance to work with Betty on my right, Rose, and CP, no, and maybe another nurse taking care of sedation, Ayati. So Ayati is okay. Okay, I'm not so bad. So you see the stent. First of all, this of course this is a uncovered metal stent, but it seems to, yes, here maybe it has been fractured here. You see? Okay. You see? Okay. Partly destroyed here. Okay. And then you have a plastic stent inside. So I don't think we can, frankly speaking, we cannot remove it. It's impossible to remove this stent, of course. We can try, but I think we can, maybe we can remove the distal part or break the distal part, but we will not remove the part which is inside the bile duct, okay? So I think forget to remove it, if you agree. So we will remove a plastic stent and we will insert another stent inside. Can we have a look on the fluoroscopy? Just to have a look on how it looks like the stent, in fact. So I don't have any, I don't have a pedal. We can have fluoroscopy, please? Yes, you need to turn. Yes. Thank you. And just, you change the positioning. Yes, sorry, okay. Yes, now we better, yes, okay. Have a look. Fluoroscopy. Yes. We are not in good positioning. Good positioning. Okay. Now, why not? No, you have to go down. Yes. Stop. Yes. Yes. Okay. So we still a stent. So it's a long stent, more or less 6 or 8 French stent. So we will remove the plastic stent with a snare, open, and following removal, okay, we will insert. 1 minute. It seems to be not so obvious. Yes, because the snare is yes, it is a small one. 1 minute. Okay. You can open. Yes. Okay. Now, 1 minute. Okay. Open again. Open again. Sometimes it looks simple, but sometimes it's not so simple. Yes. Now. Okay. Close. Close. Okay. Perfect. I think it's better to remove with a scope. Okay. So I'll remove. I think. Okay. And we go back. So any other option you see? You have any other option? The purpose is to insert an uncovered metal stent inside. In fact, open the snare. Open the snare. Yes. In fact, the patient. Unfortunately, he has a pancreatic carcinoma, and I think with metastatic lymph node. That's why it is a palliative treatment. That's why I think probably the more reasonable is to insert uncovered metal stent.
Professor Ponchon, what is the length of the stent that you want for this case?
I think maybe. Sorry, this one is maybe 8 centimeters. The one which is in place. Yes. It's a little long one. It seems to reach the hilum. I think I will inject.
Would you first do a cholangiogram?
Yes, I will inject to see how is the stenosis, because the stent itself can induce some hyperplasia.
Right.
So I want to find a stent to cover all the hyperplasia and the malignant stenosis. So initially, I wanted to insert a 6 centimeter long stent, but maybe I will be obliged to insert 8 centimeter. So I think 8 is always too much, because I would prefer to insert a 6. 4 is sometimes too short.
The challenge now is to go through this fracture stent.
Yes, but okay. You need to follow the way. We will see. So for this, as you know, we are using now Fujifilm endoscope. Yesterday it was Olympus, and yesterday we used Boston Scientific Papillotome and Olympus, and now this is a Cook. So all the companies have been involved. But it is nevertheless not reasonable. You can never remove uncovered stent, except if you insert inside a covered to destroy hyperplastic tissue. But this is nonsense in this case, because this is not a benign disease. This is a malignant disease. So,
Professor Ponchon, sometimes when we do reintervention for metal stent, when we pass the guide wire up, it goes in between the mesh.
I know.
So could you demonstrate to us how you overcome that problem? Do you use a curved tip wire?
No, I use. I don't want to say it's by chance, but I use usually an angulated tip. Yes.
Yes.
That's why it works. I usually use, but I try to go as fast as possible. Now you see the here does not work. Okay, so I need to stay online. Okay, now can we have a fluoroscopy? So please, fluoro, yes. Ah yes, okay. I don't see so well. Okay, push the guide wire. No, stop. This is the problem. 1 minute. I need to find a better direction. Maybe this one is better. Now, okay. I pull on the guy. I pull on the yes. I pull. You see, I pull on the papillotome to be straight. Maybe it's not so good, but I will try. Okay, push the guide, right? Push. It seems to be better. You see, because the guide wire is not going out of the. So now have a look. Yes, but nevertheless, yes. No, the guide wires come out. Okay. So no, I need to use the okay, because the papillotome should be straight. You understand? Like this. No, look. Okay. No. Okay. So I need to be really straight. Like this. You see, I try to be straight like this. Okay, push. Yes. Yes. Okay, because well, it's nothing, because I was very straight, perpendicular. Perpendicular. Okay, now we need to be sure that we are not passing through any mesh. But I don't think so. It's even at the you can go at the upper part.
Can we see the
upper part?
Upper part.
Upper part.
Looks like it's passing through a mesh.
Maybe. Yes. So, but it's not a real problem if yes, it's passing. Maybe not. I don't think so. Can you inject? Not sure. Then it's difficult to know. Quasi impossible to know. I don't think so. No. Stay at yes. Show me the upper part. Yes. Perfect. No, not so much. No, in between. Stop. Okay. Now, up. Inject. Yes. No, okay. My fault. No, my fault, because, okay. It's my fault because I did not push enough. inside the duct, the papillotome. But you see the papillotome seems to go easily inside the stent. Okay? So now inject. Yes. That's we can do. Yes, it's okay. So what we can do is that can you bend the papillotome? Bend the papillotome, okay? Push the guide wire. No, seems to be free inside the stent, you see? But nevertheless, very difficult to know, huh? Maybe we are.
Would you do a small balloon?
Is it possible to approach the screen, because the screen is too far? So I think maybe we're out, but it's difficult to know, huh? No, what I need to do, yes, okay. Okay, now scopy again. Maybe we go out of the stent. Maybe only the top part, okay. So I go down a little. Scopy. Scopy, scopy, scopy. Yes, we are out, you see? Okay. Okay. Now, you go back with the guide wire. Go back, go back, go back, go back, go back, go back, go back. Go back, go back, go back. Go back. Totally. Show me. No. I tried to push. Yes, show me. No, okay. Now I go down. Don't bend the endoscope. Don't bend the. Okay, no bending. No, show me. So now push the guide wire. And now we go out. Huh? Okay, this is not good. So I try to be. Show me. No, push the guide wire. Now we go out. So maybe we need to change for a balloon, for example. Huh? You understand? If we put a balloon, maybe we will have better chance to say within the lumen. Okay? Push the guide wire.
What wire are we using?
Now we are. Now okay. Now we are okay. Okay. Now we are okay. I think we are okay because.
Are you there, Wakyong?
The audience is asking what wire are we using.
Now we are okay. Yes, now it's okay.
We're using VisiGlide 025 wire.
Yes.
Right,
we were discussing earlier whether angle tip would also would be better in these situations, as when it forms a loop, it will go through
we need to inject in
easily.
Contrast. We need
And
to inject in the contrast.
To use a balloon.
We need to inject in contrast to see the stenosis. Please inject. Yes. I go down. You see, I go down. Yes. Okay. So what I will do is okay. So I will measure. So here I'm here. Okay. So 1 minute. Copy. Fluoro, yes. So I pull back the papillotome and you push a little the guide wire inside, okay? I pull back, okay? Scopy. You go down, scopy, go down. Go at the lower part of the, okay. Go at the lower part. Go at the lower part of the bile duct. Fluoroscopy, lower part of bile duct. Yes. So that means we need at least 8, huh? Because 6 is too short. Yes, we measure, but it's good. Yes, it's 10, but I think 10 is not realistic. Because 10 is not realistic. So even if a stent inside is here, it's okay. Okay? I think 10 is. I never said 10 centimeter long stent. It's impossible. Push the guide, right? Even 8 is long, but nevertheless, 8. Okay, so for this we will use a MI-Tech. Huh? This is MI-Tech?
No,
you changed for a Taiwan. Okay. I
Taiwan.
thought it was a MI-Tech. No, it's a Taiwan. Okay.
It's a
No
Taiwan
problem.
uncovered stand.
I manage. I adapt myself. Okay. So this is an uncovered stand, huh?
This is an uncovered Taiwan 8 centimeter stand.
Okay. In my unit, we are using MI-Tech, we are using Taiwan 2. Okay. It's okay? Betty, you follow
Any
me?
questions from the floor?
You follow me,
Aman?
Betty?
Wakyong, can we look at the stand, please? The stand image.
Okay. Can the cameraman zoom to the stand?
Who is the cameraman?
Okay, this is a delivery system. Okay.
Which is, they looks more or less all the same, huh? And you see this one, the marker is more white. Usually it's yellow, but it's white. Okay. If you have a look on fluoroscopy, for example, fluoroscopy.
So this is a 10 cm stand.
So
Am I
you
right?
see? Okay. Perfect.
How many?
So
8 centimeter.
Only 8, just
it's
exactly
8
the same
centimeter.
length.
8 cm. We felt that 10 cm is too long for this distal
Yes.
structure.
Oh, okay.
Because I
But
measure
the
the
original
but
stand is also 8.
yes, I measure. Sorry, I measure the length easily when I pulled down the papillotome, and with the marker of the papillotome I could measure the length of a stent which is in place. For me, it cannot be a 10, so it's a 8. It's for sure it's longer than 6.
Why you choose uncovered stand? How about covered stand?
Because it's
Any reason?
it's a palliative case, and so there is no need to remove this one first of all, and there is no need to change the stent, in case, and there is less risk of migration. So uncovered stent is the gold standard for palliation.
Yes, indeed. There are meta-analysis that shows that covered and between covered and uncovered, the patency is about the same actually.
Yeah, yes.
There are different meta-analyses that yield a different result. But one latest one, they say the patency is the same, but the migration risk is higher in covered.
Yes.
The
So
tumor ingrowth is higher in
yes.
uncovered, but the tumor overgrowth, that means growing on top of the stand, is higher in covered stand.
Sorry.
So it equals each other advantage out.
Yes. The only problem is is related to the cystic duct. But in this case, we don't see the cystic duct because of the previous stent. We don't care with the cystic duct. Pull a little. Yes. Tension. Yes.
I think from the cholangiogram you saw just now, there is tumor overgrowth above the metallic stand. Isn't it, Professor Ponchon?
What?
When we did a cholangiogram just now, it seems the tumor has overgrown the stand.
Yes.
The occlusion happened on top.
Yes. So.
Professor, the question here is there any role for radiofrequency ablation before stenting?
Excuse me? Is there any role of
Radiofrequency ablation before we do stent within the
This
stent?
could be possible. Yes. But we are conducting a study now in France in patients with occluded metal stent. We use radiofrequency. At least we conduct a study. Yes.
Any result you want to share with us?
No, it's too early. Pull a little. I'm just a little in trouble, I must say. You see?
Walking, are you aware of any existing literature on the use of RFA in prolonging the patency of the metallic
Show me
stent?
the. Because.
I'm not aware if there's any published paper, but certainly in abstract form, there are
Question.
some early results suggesting that it will be helpful.
I don't want to. You see, I have a little problem. You see, the problem is that
But in this particular patient, I think the reason he has been having deranged liver profile and a bit of cholangitis on and off is because of the fractured stent, and some debris get trapped, resulting in the cholangitis rather than the tumor itself. Yes. He has been responding quite well to chemotherapy.
In fact, I got a problem when I pushed the stent because my stent was trapped by the stent in place. I have a feeling that I had a good feeling. I did not think I passed through through my mesh, but I was stuck. And now have a look on the upper part, fluoroscopy, to be sure that 8 is not too long. Yes. Upper part. Yes. Yes. I think it looks a little long, but once it is deployed, should go down, huh? But yes.
But there'll be a shortening, right? There'll be a slight shortening, I think.
Okay.
After
So now you deploy. Deploy. I'm a little in trouble nevertheless, huh? Because I don't want to be too up. Okay. I don't think it's too long, but yes, yes, you can do it. Slowly, slowly we follow. Okay. Continue, continue, continue. Continue. Yes, deploying, continue. Okay, 1 minute, 1 minute, okay. Yes, 1 minute, 1 minute, 1 minute. Sorry, Scooby. Okay, now I'm feeling a little better. Yes, continue. So just to, yes, I just have to pull. Continue, yes, yes. Seems to be a little high, we'll see later. 1 minute, 1 minute. Scopy. I hope we are not too high, huh? You see? I will pull a little. Even if we are a little outside in the duodenum, it's not a real problem, huh? You understand? I prefer to be a little lower. Now show me. Because we are still high, but should deploy, huh? Continue. Yes. Continue. Continue. It's okay. It seems to be okay. Show me. Yes. Maybe we are a little high, you see. 1 minute, 1 minute, 1 minute. Stop. Show me. Maybe 6 was better.
But it has come down, I think.
It's come down a little, but I need to be at a distance, you see. I need to be here, because then it's too high, okay? But it's okay, huh? Yeah. Show me. Now it's going better, now, okay? Deploy. Yes. Yes, continue, continue, continue. Continue. Okay, show me. I can.
I think it's okay now.
It's okay, yes or not?
I think it's okay now.
Yes, it's a yes.
Yeah,
it now.
Go down further. It's okay. It's okay now.
Yes, continue, 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 continue.
Yeah, it's okay now.
It's deploying
it's
better.
Only about 1
yes.
cm, 1 cm more, 1.5 cm above the previous stand.
Yes. 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 It's not bad. No?
Yeah.
No, on the opposite, it's quite good. Yes, yeah, continue, continue. It will be a little longer, but yes. No, it's
Excellent.
okay, it's okay. Okay.
Wonderful demonstration.
Okay. I don't want to compare Taiwan to MITech. They are the same for me, okay? So now I'll stay polite, huh? Okay, perfect. It's okay.
It is perfect.
Are there any questions from the audience?
Okay, well done, well done. Well done, Gary. Yeah, so this is a stand in stand, huh? Okay, right. And we won't worry about a fracture. But you did mention that you may want to take out that outside part that is fractured. Would you use an APC to cut it off or whatever? But I don't think it's necessary, isn't it?
in other situation, would you consider removing part of the fractured stent, the outer part?
Frankly speaking, it's impossible to remove. I've tried several times. It's impossible. Only what we can do is you can insert a covered metal stent and then to try to destroy hyperplastic tissue and then to remove a stent. But then it is nevertheless very difficult. Even a partially covered stent, even if you have only 1 centimeter uncovered, it is really a nightmare. It is a nightmare to remove. So, unfortunately, when you have an uncovered stent in the bile duct, it is very difficult to remove. So the only method I'm using, I perform a percutaneous approach, a cholecystoscopy, and I destroy the stent with APC or with a laser. Yeah. Then I destroy, and I remove all the small pieces of the stent. But only in case of benign stenosis, when unfortunately my colleagues, they insert uncovered metal stent.
Thank you very much, Professor Ponchon, for the excellent demonstration. I think Professor Nantali is ready to demonstrate a linear EUS examination in room 3.
Right, just to recap the history again, we shall present the history because can we have the history again for room 3 before we pass it over to Professor Nantali?
Madam SS, a 71-year-old lady with underlying hypertension, had an OGDS revealing subepithelial lesions at the fundus of the stomach. EUS showed heterogeneous lesions arising from muscularis propria, about 2 centimeters. We'll be performing the EUS FNA today.
All right, over to you, Professor Ida and Professor Nantali.
Okay. So, okay, why don't you start, Nantali?
Hello. Good morning again, everyone. So, we're doing somewhat a difficult case, right, Ida?
Yeah.
So this is a subepithelial lesion suspicious for GIST, and it's located in the fundus. So that's, one of the difficult location right there. So if you guys can focus on the EUS image, you can see the lesion. Do you guys see the EUS image there?
Yes, you can see.
Okay. Ida, can you help me with the cursor?
Sure.
Yeah.
Sure.
Yes. So Ida is pointing out the lesion of interest.
Hold on. I'm sorry.
Yeah.
Okay, here we are.
You see that hypoechoic lesion that's arising from the muscularis propria, the black layer there. It's very important when you do all these examinations on subepithelial lesion, you want to look for a transition point. And as Ida is pointing out right there, it's coming off of the MP layer, which is the 4th layer. And that is very suggestive of GIST. And when you examine the GIST, especially in the stomach, you also want to look at the celiac area to look for celiac nodes as well. For GIST, you can have hypoechoic lesion, you can have heterogeneous lesion, you can see sometimes central hemorrhage. It bleeds very easily. So the size of the lesion is about 2 centimeters. Okay. Now, what I like to point out here is that if we can switch to the endoscopic view.
Yes, you can see the endoscopic view.
Yeah, you can see the endoscopic view, right? So I'm going to show you. It took me a while to find that lesion, and so this is antrum, this is body, and I'm using a linear echo endoscope by Fuji, which is a very good scope. So to get into that lesion, I have to do a complete retroflexion. Now I'm doing a retroflexion. Usually for EUS scope, it's quite challenging to do a complete retroflexion, but I think the scope is quite flexible, so I was able to do so. I'm going to put a little bit of air so you guys can see where the lesion is located. So can you guys see the lesion right here? Yeah, you guys see the lesion right here? So it's just a little bit below the cardia. And in order to reach that lesion, I have to do a complete retroflexion and put my scope just right at the lesion right there. And now we can switch back to the EUS view. And if the camera can focus on my scope position right here.
Oh, do you want to unfreeze it or? Yeah.
So you can see how I have to bend the scope so much, and I have to look up all the way. And if you can focus on the EUS image at the same time, as I'm looking up and talking all the way to the left, I see this lesion. So if you put the fluoroscopy over here, you're going to see that the scope goes like, you know, almost 180 degrees, okay? With this position, it's going to be very challenging to do an FNA. But what I'm trying to do here is that, as I said before, needle selection is very important. So Ida, what do you think needle we should use here?
Yeah, so I think 25 is the absolute must. And then, I mean, I think when it comes to GIS, and we were talking about this, that obviously it'd be nice to have core tissue.
Right.
But the problem is the Pro Core is a little bit stiffer, the 25 gauge. So, and really this is very challenging. We wanted to give Nontali a very, very easy case first thing on Sunday morning.
Yeah.
So I think in this case, perhaps we will choose the 25 normal needle, actually, the expect needle. Yeah.
So lots of people advocate using a 19 gauge needle for GIS, for core tissue, but for this particular case, I don't think I can do it with a 19 gauge. I'm going to try with 25, and if the 25 doesn't do it, then it's going to be very unfortunate.
Yeah, then nothing will.
So to put in the needle, so let's just get me the needle. So the needle that we're going to use is going to be Echo Tip 25 gauge needle from Cook. Okay. We were planning to use Procore needle earlier for core tissue, but again, Procore is stiffer than a regular Echo Tip. So we're going to go with the Echo Tip. And before you put in a needle, you have to straighten out the scope. So if you come back and look at my hands on the scope is now in neutral position. I have to straighten out everything, because if you keep the scope bent, a lot of time you can keep the scope bent and put the needle in there. But this particular patient, the scope bends like 180 degrees. So if I try to force the needle in, I can easily damage the scope. All right.
And Fujino will be a bit.
and the people here won't be happy with me.
Excuse me, Profida.
Yeah. Sorry.
Excuse me, Profida.
Yeah.
Suresh here.
Yes, Suresh. Yeah.
Sorry, I want to know what is the symptom of the patient that requires
symptoms?
I mean, it's asymptomatic. This is an incidental finding. It's the usual thing where somebody has an OGD, and then after that, this was found on OGD, essentially. Yeah. Sorry, she was iron deficient, actually. Yeah, you're going to ask why are we doing it, of course.
For the workshop.
Yeah. Well, I mean, the question, I guess, always is when should you puncture or a gist?
Exactly.
There's no hard and fast rule to that. I mean, if Nontali can actually, I would welcome Nontali's view. But it is quite it is 2 centimeters.
So is it 1 centimeter your cutoff, 1.5 centimeters, or 2 centimeters?
My cutoff is 2.
All big lesions.
So it's about 2 is probably about the kind of cutoff that we would be thinking about. Yeah. So
it used to be the guidelines used to say 3 centimeter is the absolute indication for resection, but now I think with the newer guideline it says 2 centimeter. And if your patient is symptomatic from the GIST, for example, anemia from bleeding GIST, that's the indication for resection. There's really no need for FNA. But for uncertain etiology, if you're not really sure what this is, then FNA is one of the things that is recommended.
I mean, again, I'm not a surgeon, so I don't really know, but I would imagine, I don't know. I mean, I would take advice from a surgeon from this.
Okay, Professor Sanjeev has something to comment.
Okay.
Sanjeev,
yeah,
please.
Sanjeev.
No? It's a Sham.
Shamila, please. Shamila.
Hi, Nontali.
Hey.
Hi. I'm going to be the devil's advocate. And, personally, when I see just tumors, I'm kind of against FNA unless you absolutely have to, because there is a capsule.
Can't hear, Sham.
I can't hear you, Sham.
We can't hear.
Okay. Hi, now? No? No? Sorry. Hi, can you hear me now?
Oh,
yes,
yeah, that's
now
much better. Okay, good.
Okay.
There is some argument to, just monitor these patients with even just 2 centimeters, asymptomatic, incidental finding, no worrisome features. I personally, GIST tumors, I have reservation in puncturing them because they have a capsule and there is that tiny risk of seeding. And the other thing is you need to get enough tissue for Chi-67 to make some decision. But I think looking at this lesion, initially, it doesn't look quite homogeneous actually. You can see that it's a bit hyper-echoic and it's not totally homogeneous.
Yeah, I agree with So I agree with you, Sham. I think it's both. The thing is, I guess that's what I was going to say. I mean, this is a bit borderline, and I think the question, of course, is whether to monitor. What about surgery, because it is heterogeneous, and whether or not it's technically easy or not, because it's right at the fundus. That's why I said I don't know what the surgeons would feel about this. And she is 71 years old, so I agree that there's a lot of controversy, really, whether or not to puncture a GIST. Nonetheless, if it was in your practice, would you do it, this case?
I have to admit that for subepithelial lesion, I like to puncture.
Okay.
I do like to puncture, especially when it's sort of like debatable between us and the surgeons whether or not this should be resected. Back in the day, my surgeons, the MIS people, they said anything more than 2 centimeters, they would recommend resection. But now they've gone in and got quite a few cases of lymphoma. So now they're like sending 90% of their patients to me for FNA prior to resection.
I mean, I think that's right. It's also what the surgeons want. Yeah.
But this lesion, I mean, it doesn't appear to me as though it's a lymphoma, although we really can't differentiate it by EUS morphology.
And she has some lymph nodes. But you see, again, I don't know if a 71-year-old woman like her would actually just, go for surgery without any tissue, without saying.
No,
go for surgery.
I think the bottom line is that, to deliver the correct message to the audience. Exactly. I think Sharmila I'm totally with her in terms of, asymptomatic, small lesion, no concerning features. I think this can be followed. But again, there's no like absolute regulations and rules. So I think it also depends on your practice as well. I think we can do either way, honestly. Yeah. Okay.
Thank you very much for the discussion.
Yeah.
We're just going to switch to room 1 because I think Professor Arthur Cafes is ready over there.
Okay.
Can we have the history for the patient in room 1, please?
Miss KSG, a 64-year-old lady, had an incidental finding of an abnormal liver profile. ERCP was done showing CHD stricture with gallbladder stones, Curie-Mirizzi syndrome. She underwent laparoscopic cholecystectomy. However, a repeat ERCP in January 2018 showed persistent Curie-CHD, Curie-right IHD stricture, not allowing a 10 mm balloon through, thus was stented. Brushing for cytology was negative for malignancy. They'll be performing an ERCP and spyglass today. Over to you.
That's enough.
We are on.
So stop, everyone stop. Yep.
Right,
Hello.
Professor Cafes, you're on air now.
Right, okay, so you've heard the story of this patient. Yep, you've heard the clinical story? Okay.
Yes.
So do you have the cholangiogram? Can you hear me?
Yes, Arthur, go
So
ahead.
you have the cholangiogram?
Yes.
Okay. So we removed the plastic stent that was in position and we're performing a cholangiogram. And obviously in these cases it's difficult when they have a sphincterotomy and all the contrast leaves to get a good opacification of the stricture. So we're going again with the balloon occlusion. So let's screen for a minute. And we're going to inject some dye for you. I'm just going to impact a little bit there, inject the dye. And you can see there's a little bit of tapering around the hilum there. I'm not seeing the left at all, which concerns me. So stop there, balloon down. I'm now going to, it's a little bit tight, screen. Balloon down. Down, 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 that's it. I'm just going to push past it again. It goes pretty easily. And then we're going to inflate the balloon to 10. Yeah, you can screen there. You can see the balloon will go up. A little bit more balloon. And screen there. Okay, so a little bit injection. So we're going to inject as I pull back. And it comes through quite easily. It's a little bit irregular, but it actually comes through with virtually no resistance. But my concern here is that there's no filling of the left duct. Something's not right. So I think that actually what we should do now is we've determined that the stent has had some positive effect on the right hepatic duct, which is still very dilated with a bit of narrowing and tapering. But that may be just, you know, a stent effect. But we've lost the left duct. And that's very suspicious for a possible tumour. So I think now what we're going to do is put a spyglass up and try and have a look at that hilum and see what's going on, which was a little bit unexpected. But we can have a look at the right system and then see if we can look at the orifice of the left system. And that's our strategy for today. Any questions at all from the panel? Any comments or questions, Deflate?
Excuse me, did the patient at MRCP? Has it been carried out?
Look, an MRCP would be very useful, but we didn't need it because we had a very good ERCP. So we had a good cholangiogram.
Agreed.
But now things have changed a little bit. So if you remember from my lecture this morning, I said that if we don't pacify a lobe, we don't need to drain it. So my attempt today will be to have a look at that right hepatic duct and just look at the origin of the left hepatic duct and biopsy and sample it. And I think that if I don't instrument the left duct, that might be a good thing for the patient. But I'm not entirely sure. We'll see how this develops. So we're feeding the spyglass down. And what I've done and what I do back home is I use the picture-in-picture function on my duodenoscope and Olympus processor. So we put a video cable from the spy in the picture-in-picture function, and now I can control it with the number 4 button on the duodenoscope. So if you're watching the endoscopy image, you should now be able to see the spyglass image. Yep.
Can we have the endoscopic image enlarged, please?
So we're just going to strap the spy-scope to the duodenoscope, and as you know, it's a single operator system. Can be used as a dual operator system. There's no problems with that, but and often being at most tertiary and quaternary centres will have usually 3 or 4 people, so you could have everybody having a go at the spy. But so what we're going to do is usually I angulate, and I can lock that angulation. So I create much like a sphincterotome effect, and then I can use my dials. I'm just using my up-down dial to get into the duct, and I will now have a look here. So now I'm actually inside the duct. And usually what I do is I'll leave my locking device on, and I can adjust my view as I go. So we've got the water pump, so let's just put some water in. Always good to put water in. And we'll screen.
So I think for the audience, we have been showing spyglass year on year. You see that starting from last year, I believe, we started showing the digital spyglass. And indeed, it's a world of difference. From the first version of the spyglass. And Arthur, you would agree, from the first version of the spyglass, which we struggled so much, to this digital version, which the unit had bought last year, you can see a world of difference. I think the audience should appreciate that this is actually very good cholangioscopic views.
Yeah, there's no doubt it's night and day, isn't it? Night and day. Screen there.
The only other thing is the passage of EHL and laser fibers. That's still the tricky part. That's still very, very tight, isn't it, Arthur?
It's still a challenge. Look, I think we've got a tumour here. We've got mucus. Oh, maybe not. We've got some abnormal mucosa. There's a stone there. But the stone may be artifactual. You know, we've had a stent in there for a while. We know we can get a lot of debris.
No, the first time I did her, Arthur, she had stones. And she did not have the gallbladder operated. And then I removed all the stones and there was a stricture. Then I put a stent. Then I called a surgeon in. And surgeon said, oh, that's going to be tough to handle surgically. I'll take out the gallbladder and see whether it improves. So this is where we are at this present point in time. It's the second time a stent is put in already.
Yeah. Screen, please. All right, so we're right there at the origin of the hepatic ducts. So it's very important when you do spyglass that you follow the cholangiogram. I did have a colleague who doesn't like putting contrast in because he feels that it disrupts his ability to see where he's going. But I think with a lot of irrigation, that's not a big deal anymore, and it's important to follow your anatomy quite nicely. So screen there. So you can see I'm now looking right into that duct, which is the right hepatic duct. And you can see I'm just slowly adjusting. Do we have a suction? Can we connect the suction? Connect the suction. So it's also important to have suction available. And that's good, thank you. Now screen there. All right, so we're right up in that duct now, okay? There's no doubt about it. I'm just trying to orientate a little bit better and put some fluid. Small amounts, not overdone. And I think the mucosa here looks quite good, really. The ducts, the lining of the ducts looks quite normal. There's a little bit of damage there, probably from the stent. There's a bit of a villus pattern occurring on the left side. Do you see that? Can you appreciate that? Actually, now it's almost circumferential. It can be difficult. There's a stone impacted right there. Screen. But that's still pointing out into the right duct. So this all could be tissue reaction. I think there are criteria trying to determine whether it's benign or malignant, looking at papilliform structures, looking at vascular abnormalities, but I find that it's a bit unreliable because you can get that with inflammatory change. And you can see there's some abnormal vessels. You can see that it's a bit papilliform in certain stages, so it's a little bit unreliable, particularly here on the left. So I think that in these cases, it can be challenging, and this is where we'd look to do the spy bite and obtain some tissue. Now, what I would like to do at this point is just look at the origin of the left. So, nice stone scene there. Just screen for a moment. So now I'm going to try and turn my scope in the other direction. So I'm pulling back just a touch. I'm following the image. Very slow, you know, no need to be quick. Screen. So now we're looking over it to the left hepatic duct, which is completely occluded. So I'm just going to pull back slowly here. Still not entirely that easy, but again, a lot of those changes are concerning, aren't they? A lot of congested vessels, very erythematous. It's very narrow there, that's right. There's no real movement. So this is my target for biopsy, right on this spot here. I think this is the key area screen. I'm definitely pointing in the right direction, and I think this is my target for biopsy. What do you think? Yeah, let's go spy bite.
Yeah, looks like the right position, Arthur, to biopsy.
Yeah. It could still be benign. It could be just a lot of inflammatory reaction. You know, it's hard to tell.
Especially with the stent in place for
a
couple of months already.
Yeah, the stent, the scope, Okay, so often you have the stent reaction, you have the stone reaction, all of this. Now, what's very important when you're doing spy bite, again, is just go nice and easy. There's no rush here. We're going to slowly feed it down. It can change through the stiffness, the position of your scope. So you just got to always go very slowly and adjust accordingly. And when you open and close the spy bite, you do it slowly. Everyone's always in a hurry to open quick and close quick. You need to go slowly to get a nice tissue capture. And I'll show you that now.
Are you having trouble passing the spy bite up, Arthur?
No, not at all. Not at all.
Not at all, huh? Yeah.
I haven't reached the critical part, which is the tip, but the tip's very straight, so I don't imagine I'll have a problem. And I've got a good view. And keep,
that's a bit of villous changes here.
Correct.
Exactly here.
Correct.
Questions?
So I think a lot of these findings are unreliable. I don't think they're that accurate. You can see nicely that it's come through minimum resistance.
Yeah, the spy bite passed through the spy scope very easily.
Yeah,
but,
yeah.
I mean, in our experience, when we try to do lithotripsy with the EHL probe, or sometimes with the laser, we sometimes find it difficult to pass through the tip.
Yeah.
There's a question from the audience. Dr. Hairul, please.
This one you can check the wire through the spy scope.
Can you pass a wire through the spy scope to try to access into the left ducts?
Yeah,
that's the question.
Of course. But I don't think I want to.
Yeah.
Because then I'm committed to accessing the left duct, getting a stent through, dilating, so on and so forth. I think I've got a very good target here to make a diagnosis, and I don't have to really compromise cholangitis and so forth if the patient's a surgical candidate. So, and yeah, look, what tips and tricks to get something through the tip? Sometimes you have to go past the pathology. If it's a stone, you go past it, straighten out your tip, and then you can pass it and bring it back down to your target is often a very simple way. Open, please. So we jiggle a bit so we can transmit the forces. There it is. And when you close, I want to close very slowly. So I'm going to push up against that mucosa. It's pushing away a bit. And close slowly. Happy? And I should feel a little tug as I pull it back. I should feel a little, yep, and it pops. So now I should get a good piece of tissue. And we can put that. Let me ask you a question. Should we put it in formalin or should we put it in cell block?
I would
formalin.
think to be formalin, yeah.
Yeah. So we did a study back home looking at or comparing, because a lot of people are frustrated by the samples in formalin that they are too small and they can't be processed and often they're thrown out. So we did a study looking at these very small pieces going in a cell block. So what our pathologists would do is put it in a saline cell block. They spin it, centrifuge it, remove all the liquid out, and then put in some paraffin to block all the small bits together, and then they put it in for histological analysis. So it doesn't matter how small the pieces are, they all get blocked into one and form a big block for histology. And that way, we find that we can process and assess all the samples. But this is a very nice straight shot, and I'm feeling we're probably getting good sized tissue, so I'm happy to continue this way. But we're doing a further analysis, a prospective randomized study looking at the comparison between the two techniques and the diagnostic value. So
Yeah, thank you, Professor Cafes, for demonstrating a very nice spyglass view of the cholangioscope. We shall now move to room 3 to conclude the case before we actually proceed to another case in room 2. Can we have Professor Nontali and Professor Ida just to conclude the case and before we switch the room? Yeah. Professor Nontali? Yeah, you're on air.
Hi,
now.
I'm back.
Yeah.
Okay. So when we were off the camera, what we did was we did an FNA using the 25 gauge needle. So we were able to get tissues, and I'm gonna show you the specimens that we're getting. So it was challenging in terms of the position, but luckily we were able to advance the needle in without difficulty. Now Ida is coming back with the specimen. Can you focus on the specimen? So we got some good pieces of tissue.
Yeah,
as well.
Nontali didn't want to do it on camera because he said the positions that we were in were not,
It was very acrobatic.
Yeah, acrobatic position to
Yeah.
get the sample.
So we did 2 passes total.
But it was very good. We've got the image here, so can we get that?
Not a whole lot of bleeding. No bleeding at all, actually. So here we're gonna here.
Yeah.
If the camera can focus on the EUS image. So that's the.
Can we have the EUS image,
you
please?
guys see the EUS
We have
image?
the US image. Yeah.
Yeah.
Continue.
So.
Yes, we can see.
So this is. Where's the cursor? So you can see the needle going into the lesion, and we just did the fanning technique. So that's pretty much what we did.
Yeah.
Yeah.
Sorry, we can't have a cursor for that. Yeah, so you can see the needle though going quite nicely inside. So I think it was a very tough position. So I think really, Dr. Nontali needs,
Great job. Yeah.
deserves a round of applause.
Okay.
Yeah.
Yeah.
Okay.
Thank you very much. Thank you.
Congrats. Well done.
We will
well
now
done.
move to room 2. Can we have the history for the patient in room 2, please? Okay.
Miss LSY, a 24-year-old lady with metastatic pancreatic neuroendocrine tumor, had an ERCP in January 2018, showing distal CBD stricture and plastic stent was inserted. You'll be performing the ERCP and insertion of metal stent today.
Over to you, Professor Ponchon and George.
Okay, so same team than 30 minutes ago. It's a little tricky because the plastic stent, the lower part of the plastic stent was located exactly at the level of the papilla and tends to disappear. So finally, if you have a look on the fluoroscopy, we can have a fluoroscopy. Fluoroscopy, yes. Finally, what I did is I could not remove the stent because I did not see the stent, or at least partly. So what I did, I inserted a guide wire within the stent, thanks to a papillotome. So this is a VisiGlide, and use a papillotome from Boston, and then I succeeded, maybe many by chance, to introduce the guide wire within the duct, within the stent. So you see the stent, the guide wire inside the stent. So now I'm using a Soendra retriever system, okay. Soendra retriever, and I use it now mainly to delayed stenosis. This is a metal sheath retriever, but I'm rarely used to change a stent. But in this case, I think it could be helpful. So this is a Cook. It's a Cook product. Soendra retriever. So you can yes, pull a little on the guide wire. Yeah, not so much. Okay, just a tension. Tension. So it's a little. That's why it is tricky. In case it does not work, you can introduce a balloon inside the stent, but not a dilated balloon, not a balloon for dilation, a balloon for extraction. Okay, we'll see. Because sometimes it's not so easy to. Okay, 1 minute. No, don't. No, more tension.
More tension, pull back.
Yes, okay, like this. Thank you. 1 minute. A little more tension. Tension. More. Okay, stop. No, 1 minute. It will work. No, it will work. So I need to make a loop. Look, you see, like this. Okay? If I make a loop, it works. So I push on the duodenoscope and make a kind of loop, and then I can more easily push. Yes, like this. So now I need to be sure that I'm not. So we need a fluoroscopy, but is it possible to change the incidence of a fluoroscope?
Maybe you can change the patient a little bit.
Yes, because to better see behind the. To better see behind the.
Fluoro and see
fluoro. Yes.
Okay. Yes, please get the.
Fluoro. Yes.
Trace it.
Ah, yes. Now it's okay. Okay. So I think we are not so bad because we are just online with the stent. So now we can move. No, stop. You turn. Okay, you turn. Yes. Okay. Yes.
Can the camera zoom to the handle?
Okay. Stop. Show me the. Yes. Ah, no. Maybe we are not. We are not against. Huh? Continue. Yes. Continue. Yes. Turn.
So can you all see the surrender retriever is rotating?
Yes, we can see.
Turn more.
So while he's doing that,
does not always work. I have a feeling it does not enter within the stent. Huh? Turn. Okay, show me. Not so sure we catch the stone, huh? the stent. Turn more. Not so sure, huh? Okay. That's not turn again. Okay, stop. We try now I try to withdraw, okay? So don't move. Okay. So show me no, you see? Sometimes the stent at the distal part is damaged.
Yes.
So you cannot reintroduce the surrender, you see? It seems to be the case. It has been damaged because it was located. So continue to turn. We try again. And then if it does not work, we will insert a balloon inside the stent. Okay? Turn. But I don't have a good feeling. Huh? Okay. Does not go in. Turn. No. No, stop. I go down. No. Nothing.
Not following.
No, it does not. So we need to change method. So we will use a balloon, for a extraction balloon. But not so large, a small one. Smaller one. Yes, 12 is, yes, no more. So we push the guideway. Okay. So 1 minute. Slowly. You are going too fast. Your name is Betty? Yes, Betty, I go for you. Going slow. I push. Push. No, okay. But the snare, now you see the stent is a little up. So in case we can also use a snare. We can use a snare. But first we use a balloon.
Excuse me?
Yes.
George?
Yeah.
Suresh here?
Suresh, yeah.
George, I suppose this 10 French stent?
Yeah, that's right. It's a 10 French stent.
And
yes.
And so in the retriever that you use, what is the size?
10 French. Same.
10 French also.
Yes, it is the retriever which is adapted for this stent, but I suspect the distal part of the stent has been damaged because it has been blocked against the papilla, and probably it's not open.
Yeah,
it's not open.
Perhaps it's narrow.
It's narrow, yes. And that's why we cannot take it. So we will insert a balloon.
What about using a smaller French Soindra retriever?
No, it will not work. No.
Okay.
It's better to use a balloon. One minute.
Balloon will go through the previous stent?
Yes. The balloon will go through the previous stent. Yes, I think so. It's a small one, no? Yes, yes. Should go. I think. What size of a balloon? No, I should go fast. Okay. 7 French. Okay. So pull a little on the guide wire. No, but never use a balloon for dilation, because the stent explode. Is damaged by dilation. No, 1 minute. Okay. I hope it will. Okay. Scopy. Not so sure it will pass, huh? No. It does not work, huh? Okay, what we can do, that case. Yes. Yes, it's possible. Yes. No, what we can do is also we can pass a snare. I think. I can, yes. I think pass a snare could be better. Because now the stent is quite high. Initially it was not possible, but now we can pass a snare. Okay? We are losing our time. So we will pass a snare. So do you have a snare? The same snare we had initially. Oh, yes. Because this is a problem, eh? So it's
because this retrieval balloon delivery system is about 7 French.
So, but
and the plastic stent is 10 French, but the inner diameter may be smaller.
The stent was really a 10 French stent.
Yeah, it was reported so.
It's not in between 8.5. Sometimes you have 8.
We use only 7 or 10.
Only 7 or 10. In this hospital. Okay. Okay, so we go out, and I will try to use the okay. No, forget with we remove everything, because I can introduce the snare in the center. Okay, remove everything, give me the snare, and then if it does not work, we will use a balloon along, etc. So there are other possibilities. Okay. So this is the snare. You can open. Yes. Oh no! Oh, open. Take
Close,
care,
close.
Open. Just okay. Close. Thank you. I just want to control how it works. Yes.
So
And
Professor Ponchon is trying to use a snare now.
Yes, there are several possibilities. So snares, it works sometimes, especially when the stent is very up high in the bile duct. Okay. The only problem is to reintroduce the snare within the duct. It seems to be okay.
Fluoro, please.
Or 1 minute. It's maybe.
Okay, 1 minute. Hold on.
Okay, sure. Show me fluoroscopy. No, sorry. No, we are no more in place. Okay. Here we are. Fluoroscopy. We don't see. Yes. Okay. I see partly the snare. Okay.
It's
not so really opaque. You're right. You can open the snare a little. Open the snare. Yes, the snare is open. You see? It's okay. It's going along the. So now I try to follow the snare. Okay. Yes, now, yes, okay, I'm in, okay? So show me, okay, where is the snare? So I try to change the position, the direction of so I try to push the snare on the, for example, you see the snare is on the left, right part of the stand. I will try to pass on the left, you see? With a, so copy. Yes. Here I am. It's open? No, open. Open. Oh, yes. Yes, 1 minute. No, it's. I need to be very straight like this. Okay, I change the positioning. So you think that the tip of snare is close a little. Okay, okay. We'll try to pass on the opposite side. I tried to change the look. You see the position of the endoscopy is very special. Ah no, I see the problem. Is that the snare is open. Yes. Now, okay. I push again. Okay. I try to. Yes. Now it's a little better. If I try to change the positioning of the snare. Yes. Where I'm going. Yes. It's a little better. You see. I'm a little around. No, does not work so well, huh? 1 minute. The papillotomy is not so. It's not open so. Does not work so well. That's great. I'm a little. Yes, close it. Does not work so well, huh? So I have another possibility. Okay, I try once again, okay? If it does not work, we will use a balloon alongside the stent. Okay? Can you open slowly? Yes? Yes? I tried, yes, it's open, yes. Okay, I tried to push, but there is not much space, huh, you see? Does not work. So, okay, forget. Give me the balloon. So, no chance. We will find a solution.
How about inserting a basket? You think
basket?
Using basket to remove the stent?
I think basket has less chance than snare. We will use the balloon. But maybe I need the guideway to put inside. You have a guideway? Okay. Okay. So I will use the balloon, and I will inflate the balloon alongside the stent. Okay. So I push again. Yes.
Professor Ponchon, any tips on freehand cannulations of the papilla using the balloon?
It's not easy.
It's not that easy, is it?
It's not that easy. Okay. So yes, push the guideway.
Okay, fluoro need to follow, yeah.
Yes, it's not easy because the balloon is a little rigid. Yes, it's okay. It works. We are alongside. Okay. Okay. So now here we are.
Wait for a while.
Okay. So I try to be here. For example, here could be nice, huh? Okay. It's a real French, huh? Yes.
I think so too.
Okay. So now we can inflate. Inflate at the inflate at the maximum, yes. And why not to inject a little to have a bit, yes. Yes, and you have contrast, just to have a look. My only, yes, it's inflated a little too much maybe. But my only problem is that the point that
whether you can come out, yeah.
It's not so well open.
Yeah, it's not so straight.
Yes. So maybe deflate a little. It's a little too much inflated, no? Deflate a little, a little. Yes. Where is the stent? Show me the. Go at the lower part. Yes, show me. Picture. Now the stent is going down. Yes, show me the picture. Yes. The only problem is that I ought better maybe to enlarge the papillotomy. Huh? Yes, you see the stent is going out now. But so deflate a little because I'm a little too inflated.
Would you go above the proximal end of the stent?
Yes, but it's now we are in the intrahepatic left. So you see the stent going out. I try to do like this. Okay, you see, like this. I try to pull on the right. Yes, you see it, huh? You see it. Oh. Sorry. Coming down, but okay. Like to go here, like this, okay? Yes.
Wonderful.
Yes, but it's not done. Done. 1 minute, 1 minute.
Great demonstration.
This is just the beginning of the hand. It's not the hand. You see? It's not the hand. Close. No, this is the problem. Close, close, close. It's not finished. Never. No. So it's always yes.
We
Never sell. We say never sell the skin of a bear before you hunt it. So no, I need to perform a papillotomy. You have a papillotomy because it's too tight.
Show the fluoroscopic image. Where is the stent now?
The stent is just here, like it was initially.
The distal end was above the scope, at the level of the scope. So now with this effort, it has come down. The distal end.
It's a papillotomy? Yes, okay, close. No, I'm sorry, but it's at least interesting, but we need to reopen the... No, but never say it's a success, no. Okay. Fluoroscopy. Here we are. Yes, we are against. Yes. Okay. So I think we need to enlarge a little. Show me, give me the papillotome. Yes. Hold it like this. Okay. We can cut. Give me the. Yes. Thank you. Nope. Yes, show me. Can we cut a little more? Yes, probably, yes. If we want to remove it, yes, just here. Yes. It's better. Okay. So now we reinsert the balloon and we do it again. Huh? Nevertheless, in any case, we cannot succeed. We nevertheless can insert a metal stent and remove a plastic stent later. But it's more elegant to remove a metal plastics.
Can we extend the sphincterotomy, or you think it's enough?
We can extend, but the problem is that now it's inflamed, so you don't see very well the anatomical landmark. You understand?
Yes, yes.
So you need to avoid to take any risk. Okay, so I have to push a little because it's not easy to introduce the the balloon like it. Seems to be simple, but it's not so simple, huh? I push the guidewire, but I have a feeling that I'm not in a good positioning, you see? No, yes. It is quite a little difficult. I made a mistake maybe because I should have used the papillotome. Just push the guidewire. Flora? Yes, it works. Push, 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 push. Okay, okay. And now I'll reintroduce. Okay. Okay. Yes, I need to go as high as possible now. Yes, now maybe now it's better to inflate. Yes, as high as possible. You understand? Now you can inflate. Inflate. It's better. I have a better feeling. It's inflate. How much did you inflate? How much did you inflate? You can inject contrast.
The upper part of the fluoro.
So Betty is a good nurse, huh? Yeah, I think so. Yes. No, you are not sure. Betty is not a good nurse. Yes, yes, she is. Okay. No, but okay. Seems that it does agree. It does not agree that Betty is a good nurse. Okay. Huh? It seems to be not so sure.
We need to have a new English name. Yeah, now she's called Betty.
Yes, but it's not yet out.
Huh? John said, don't cut the back before you hunt. Is it?
Yes.
Don't cut the skin before you hunt. Skin of the beer.
Yes. Before the beer is not down. Yes. En français, c'est ne pas vendre la peau de l'ours avant de l'avoir tué.
Okay, where's the balloon? Behind the scope.
Okay, so maybe you can. Yes, where is the balloon? You deflate a little the balloon.
Okay, is at the level of the scope. Almost very distal already.
Alf? A little better than before. Deflate a little more.
This level, we should be able to grasp it as well.
Yes, but
It would be good to be out a little bit more.
yes, of course. Yes, you see the problem?
Yeah. How about don't take out that wire? Oh, that wire is off.
No, okay, that's.
Let's see whether it's outside. Can we see it?
No, it's not outside. It's inside.
Endoscopy.
It's inside. No, it's a mistake. It's a failure again. We will succeed, but maybe we are
Shall
losing.
we give it a try by going proximal to the proximal end of the stand?
Yes.
Deploying the intra-patellar.
What about sphincteroplasty?
Sphincteroplasty? No. Open. Oh yes, push the guidewire. We do again. No, what we could do is that as soon as
it's more of an angle rather than the opening size of the opening.
That's it. No, where it's a stent is here or not?
From the fluoroscopy.
Scopy. Show me. The stent looks here. No. No. Where is the stent? Yes, push. Yes. Okay. I do it again.
Okay, now.
Oh no, we're in the right. It's not good. Fluoro. Go down. No, go down. Go down. Go down. Fluoro. Yes. Go up. Go up. Push the guide wire. No, okay. So forget. Now maybe inflate the balloon here. Just here. Yes. Yes. Yeah, it's maybe enough. Okay. I have a feeling that the stent is here, no? On the right, no? Huh? You see? Again, we see it again. A possibility could be is if we have enough space to pass, but to pass in the same time maybe the snare is, you have a snare, but I need a smaller one because show me. I try, but I have a feeling that if I pass it along, it will be impossible. Huh? No. It's too tight. No, too tight. No, I need. Going more and more out. So deflate a little. I want to push the endoscope. You see, like this. Ah, no. It's a nightmare. Huh? Grasper. Okay, we try the grasper. Try the grasper. But I can also introduce the grasper inside the duct. But it's better, maybe better to go to another case. It's interesting nevertheless, but we are losing time. Huh?
For me, I always find it easy to use grasper to remove my graded stent.
Yes, but okay, but when you have enough space. Huh? And we also need to introduce the grasper, which will be a little difficult probably. Huh? You see? Yes, that's it. Huh? I have a feeling. Again. Okay, open. Close. It's okay? I think I catch it, plus some tissues. Oh, Betty.
Well done. It's time to
Okay.
congratulate, I guess.
It's a huge procedure. Huh? I must be proud of this. Okay, hold it. No, we don't. I don't want to introduce it. Hold it, huh? No, 1 minute. Open. Okay. It's open. Ah, yes, close. Now open. Close. It's better now.
Thank you, Professor Ponchon, for demonstrating how
it's a fantastic demonstration. Huh?
Yeah, it is. It is.
Yes.
We will now switch to room 3 first to actually look at Professor Udo. Can we have the case history first?
Mr. ICK, a 71-year-old gentleman with NPC in remission and underlying hypertension and dyslipidemia, was investigated for iron deficiency anemia, and colonoscopy noted an ascending colon lateral spreading tumor. We'll be performing the NBI followed by either EMR or AST.
Over to you, Professor Udo and Wah Keong.
Thank you, Alex. But before we continue with the case, just a bit of announcement. We have heard that there were some comments saying that cholecystectomy complications seems to be quite high here. But I'd just like to clarify the 2 cases that we saw earlier today were actually referred from outside. It was not cholecystectomy done here. So in fact, we hardly have any complications from cholecystectomy here. So much so that for ERCP, we hardly need to come in to help. Yeah, Professor Udo.
Yes.
Don't worry, we don't blame you.
Don't need to clarify. We know Peng Soon and BK is doing good job.
Yeah. So now I'm reached. This is a CCAM, and patient has a lesion in ascending colon. So, and he has a 2 lesion. This is a 1 lesion, maybe about 1 centimeter. So it looks like a cloudy shape. And I want to use BLI. Now I'm using a Fuji brand new scope, which has a optical zoom function, and also image enhanced technology, including LCI, linked color imaging, and the BLI, blue laser imaging, which is similar to narrowband imaging. So this is a linked color imaging. Basically, this technology enhances red color, more redder, and white color, more whiter. So in this region, it looks very whitish compared to surrounding mucosa. So now I switch to BLI. So BLI also lighter color compared to surrounding mucosa, this lesion. So I think this is a nice type 1. And then we switch to we get close, and we can gradually use zoom. So this is a normal surrounding colonic mucosa. So this is a really optical zoom, so you can see the capillary network, and some red blood cell is moving in a capillary. You can see the network of capillary, and also inside of the capillary, you can see the very subtle whitish slit. This is the orifice.
Yes, we can see clearly.
Colonic gland. So this is a surrounding mucosa, and this is a lesion. So you cannot see the capillary. So this is actually nice type 1. So it means a serrated lesion or hyperplastic polyp. But when we look at the central part, you can see the dilated duct crypt orifice like this. So I want to zoom a little bit more. Now you can see the dilated pit. This indicated that this lesion is SSAP, sessile serrated adenoma. Sessile serrated adenoma usually secrete many mucin. So usually duct is dilated like this. So this finding has about 80% of diagnostic accuracy. So nice type 1 and dilated crypt. So this lesion is SSAP, and also it's located in the right side, so it should be removed by endoscopy resection. So and another proximal to this fold, he has another lesion like this, very laterally spreading tumor. So I try to use BLI. So compared to previous lesion, it looks a little bit lavender or violet, light violet, or more reddish compared to surrounding mucosa. And I don't know the actual interpretation of this image, but just the finding. And when we switch to BLI, it looks browner than a surrounding mucosa. So according to NICE classification, we can say this is NICE type 2. And then when we get close, so basically the same diagnostic criteria can be applicable to BLI. So this is dilated, and but every structure is still preserved. But vessel is a little bit irregular, but still surface structure is well preserved. No destructed area is seen. So this is JNET, NICE type 2, but JNET type 2A. So still adenomatous lesion, I guess. But here a little bit of irregularity is seen. So maybe high-grade dysplasia. But basically, I make diagnosis. Here is a very regular, very homogeneous structure. So I make diagnosis as a JNET type 2 adenomatous lesion. So maybe this is also an indication of endoscopic resection. Yes.
Thank you, Professor Udo. We're just going to actually interrupt you for a second.
Yeah, yes.
We will go to Professor Ponchon, whereby he's going to insert a metallic stand. So we quickly switch to room 2.
I tried to use
okay, Wak Kyung and Professor Ponchon, you're on air now.
We are introducing a stent, which is a fully covered stent from MITech with proximal flap to reduce the risk of migration. And maybe Shan will show you the stent, okay? Shan, you are here?
Okay, so this is the fully covered metal stent. As you can see here, there are 4 anti-migratory flap at the proximal end. And the other feature of this stent is that it can be removed by pulling to the lasso here that has a golden mark on it. And you can pull it from inside out. Can you see?
Yes, yes, we can see.
Yeah?
Yes.
Okay.
Yes, yes.
Okay, we are well.
It's a covered stent, eh?
Yes,
no.
it's a fully covered stent.
Covered stent.
Because this patient is young, she's responding to treatment. But because for plastic stent, she has been coming for quite frequent stent exchange. Perhaps with this fully covered metal stent, we can keep it for a longer period of time. Maybe up to 6 to 9 months before we remove it and change the stent again.
Sure. Okay, so stop. So we see the stent. So the distal part of the stent, you have a yellow mark, and you see the distal part. It's okay. So it's a 6 centimeter long. Show me the, so it's okay, it works. So continue. Deploying. This is rose or? This is rose now, okay. Okay, rose, deploy. Okay? Continue.
Can we see the photo image?
Continue. 1 minute. 1 minute, because it's a little difficult to hold the position. Okay, continue. Yes. Okay.
So sometimes with the fully covered stent, when there's good response to treatment, the stent may actually migrate. And subsequently, when the disease progresses, the stricture forms again, and there's biliary obstruction, and patient comes back with cholangitis. But with this fully covered stent, there's anti-migratory flap that can reduce the likelihood of that happening.
Continue. Now we're in a good position. Yes? Yes, it's okay. Perfect. It works. Yes, it works. Okay,
nice.
perfect.
Good demonstration.
Thank you very much. It was a little long, huh?
Perhaps we can show the slide that we have
There is
prepared.
a thread. There is a thread here.
Oh yeah, before we do that, Professor Ponchon will show the lasso.
The lasso is just here, you see?
Yeah.
So we will not use it now, huh? So the lasso helps to remove, huh?
Yes.
But we don't need to remove now, huh?
No.
Okay.
So you use a red tooth to hold the lasso?
Perfect.
Yeah, we can use a red tooth to grasp on the lasso. So maybe we can have a look at the slides that we have prepared. There are some systematic review and meta-analysis showing that the use of a fully covered metal stand for malignant stricture. So there's less tissue ingrowth, but
Yes.
slightly higher risk of migration.
Exactly. So we already spoke about this. But very simply, in fact, I prefer to use covered stent, okay? Except when you have a cystic duct stump invasion by a tumor, I use uncovered stent, that's all. Okay. But for the rest, cystic duct invaded by the lesion, then I use an uncovered stent. That's all.
Okay, thank you very much, Professor Ponchon.
No, my pleasure.
Well done.
Okay.
Thank you very much, Professor Ponchon.
Thank you, thank you.
We will now go to room
Thank you,
1.
thank
We have
you.
a new patient there for endoscopy demonstration with Professor Ozuka. Can we first have a history of the patient, please? Room 1.
Madam RDK, a 48-year-old lady with small bowel Crohn's disease, had a flare in January 2018. Currently, she is in clinical remission on methotrexate, and they'll be performing the antegrade single balloon endoscopy. Over to you, room 1.
Hello. And now I'm in the middle jejunum. So I'm already inserted the middle jejunum. So and I already shortened the gut. And now release the angle. Oh, this is a crystal violet marking. This is around 1 meter from pylorus. Anyway, so after the releasing the angle, then using index finger and the middle finger and hold the tab of the tube and sorry, oh, I lost that. And like this using palm and so insert a scope. It's okay. And yeah, sometimes torturing or twisting the scope is okay. And now, this is the deepest point. So then, please give me the crystal violet, and now releasing the pressure. So deflate, yeah. And it's very tiresome procedure because the scope is around 2 meters long. So insert the catheter and outside the catheter is very, very time consuming. Anyway, like this. Okay. Sometimes the steep angulation is hamper the inserting the cannulation, and now it is. And wait. Okay. And anyway, spray the crystal violet. Okay. Yeah. Okay. Yes, because for measuring the distance. Anyway, already deflated, and again free angulation, and gradually insert the advance the sprinting tube like this. So
excuse me. Hello.
Hi.
Profida, are you there?
Yes.
Sorry, I want to know why are we injecting crystal violet there?
Infrared again.
Why are you injecting? They're asking.
Not inject, just spray.
Just spray.
Yeah, and the reason of the crystal violet. For example, indigo carmine is soon gone out with washing or water or gut soups, and of course, carbon tattoo is permanently continued. It's not good. The other is methylene blue. Methylene blue is so-so, but methylene blue consists only around maybe 20 or 30 minutes and gone. And crystal violet lasts around 2 or 3 hours or something. So during the long procedures, crystal violet is necessary, I think. And methylene blue is a little bit too short for marking. That's why I prefer crystal violet. And also in Japan, as for pit pattern diagnosis for colorectal cancer or a colorectal neoplasm. So every endoscopy unit has crystal burret in Japan. So that's why I prefer crystal burret. Okay. Now already, no, not yet. And single operator method, you can feel all things about the endoscope. So it gradually raises the angle and withdraw the scope and over tube. And I feel resistance. Now it means fully shortening. So now I again insert like this, using index finger, middle finger, and palm and ring finger or small finger like this. Just repeating procedures so you can go as far as possible. Oops, sorry. Yeah, this is a lumen. And now again another some regions. No. Now I now deflate the balloon please and crystal burret please. So I advance other 30 centimeters. So now 60. Totally 160 centimeters I came from the Paris. She has before she had lesion in the upper ileum. So maybe she has no lesions in the jejunum, I hope. But as for small region, small intestinal region, sometimes no symptoms, and especially subtle regions are difficult to detect by other methods. For example, MRI, CT. Oh, now again.
You found something?
Yeah. Sorry, we don't need.
Ulcer.
Ulceration and strictures. Yeah. 3 years ago, she has no gouge or a paper or please. Yeah. Generally, I use only left hand for this, but in this case, I want to use the right hand also. So to avoid to become wet handle, so I use paper. And now you can see the strictures, free strictures, and it is ulcerated. So, oh, what? What? Oh, okay. What? Yeah, okay. Anyway, okay. So, very severe strictures. And if there's no ulcers, in that case, it's an indication for the fibrotic strictures and direction. But unfortunately,
this one is ulcerated. It looks like inflammatory stricture, isn't it?
Yeah, severe butt strictures with ulceration and inflammatory strictures. So it's not the indication of the direction. Yes. In that case, fluoroscopy is important. So for assessment of this stricture, I want to use fluoroscopy and iodide contrast, please. Contrast. Yes. And during the preparation, deflating already, and I advancing a sprinting tube.
Can we have the fluoroscopy image?
Yeah, fluoroscopy image. And inflate again, please. Oh, just wait. Her hand is on the picture. Yeah. Oh, yeah. Oops. And now, but okay, then shorten the gut. Please continue the fluoroscopy. Gradually. Oh. Okay, stop. So again, go further. Sorry. Yeah. Yeah, this is the structure. So before using contrast, I want to ask total circumferential. Wow. And can I use NBI? NBI? NBI. Which? Number two. Okay. So NBI is very useful because sometimes ulceration is difficult to detect, but here white coat was covered. Ulcer was covered with white coat, so it clearly shows. Sorry. Translated? Oh. 4. Okay. Oh, one more time. Yeah. You can see the ulceration. Now back to the. And once I try to pass through the scope, I can do it. But, so I don't need contrast, but it is difficult to pass through the overtip. Again,
There's another stricture.
There's another stricture, yes. I see. So first stricture I haven't noticed yet, but now I first noticed this stricture. But so she has many strictures. So sometimes capsule endoscopy is very useful to detect subtle small regions, but in that case maybe capsule retention occurred. So in that case, endoscopy I prefer. Anyway, let me try to pass through, but maybe it's impossible. Yeah, it's difficult to pass. So now fluoroscopy. Please, yeah, contrast. Okay. And so this is a very membranous structure, so if there's no inflammation or no ulceration, it's a good indication of the dilatation, but unfortunately, this is inflammatory, so it's difficult. Anyway, okay. Sorry. Yeah. Use contrast. Please, fluoroscopy, please. Stop. And yeah, now please. It's so more and more. Yeah, and a little bit change the position because the scope. It's difficult to show. Yeah, add more. And sorry, then change the position a little bit. Yeah, continue. It's difficult to say. Can you change the position? Stop, fluoroscopy, and yeah, a little bit is okay. Maybe it's okay now. Then back. Yeah. Okay, once stop. Okay. How can you see? It's difficult to access. Again, it's. Sorry. Yeah. And this is it. Yeah. Huh? Would you please give me the contrast directory? No diluted one, please. Yeah, directly I inject from the channel. And sorry. Fluoroscopy, please, again. So a little bit more. Fluoroscopy, continue. Sorry. Yeah, it's so. And just a moment. And okay. where is the... now it is. And the fluoroscopy, please. And directly... Can you see? Can you see them? It's difficult. Yeah. So, okay. Then.
Can we take away the white of the fluoroscopy view, the white area? Take away, please. Yeah. Okay.
Thanks. So.
Screen.
Okay. Can you see well?
Can the audience see the images?
Just a scope. Okay, so fluoroscopy again, please. So gradually. Okay. Yeah, and now at the tip of the scope, please, because raw. Yeah, more. And what? Yeah. Okay. So.
Professor Ozuka, we're going to switch to room 3 because Professor Ueto is going to do the cutting already. We'll come back to you. So can we switch to room 3, please?
Back.
Yes. Now, have you seen the previous region? So now I totally deflate, collapse the lumen, and then fill it with the water. So this is a region. And important thing is that you should totally suction the air and fill it with the water. Please open. So this is a lesion. So lesion looks a little bit smaller than previous in the air. So you can put the snare.
So we are doing the underwater
EMR, yes. And then close, slowly out, open again. And close. Yes, that's it. So we could capture. Yeah, tighten. So we cut it. So as I mentioned, usually compared to injection EMR, it's a bit scary at the beginning, but we are quite sure we can preserve some mucosa better than conventional EMR. You can't see the muscle. Still, some mucosal tissue is remaining.
Yes, very nice.
And then all marking was gone, like this.
Can you tell us what is the current settings?
It's the same to a conventional EMR.
So he was using force coact for the initial cut.
Yes.
Subsequently, Professor Wedo using endocut to actually conduct the whole EMR. I mean the core underwater EMR.
So even though it's such kind of a very flat, laterally spreading lesion, we can remove it, unblock. And maybe we can put a clip easily because the mucosa is very soft. Can I? Yeah.
Is there any questions?
Yes. Clip.
Can I just ask you one more thing? When do you decide? This patient needs an ESD. I know you've done an EMR here. Would you consider ESD here?
So maybe this lesion about 2 centimeter. We usually cut off with 2 centimeter, and because Japanese social insurance cover the lesion larger than 2 centimeter for ESD, and so maybe we may consider ESD this lesion, but as you know, ESD require higher expertise. So if you can perform ESD, you can do it. You can achieve maybe 90% or more unblocked resection rate. But if you don't have a technique of ESD, you can do something for the patient instead. So I think underwater EMR can, fill the gap between technical difficulty of EMR and ESD.
Yeah.
The most important thing is achieving an unblocked resection for the lesion so that we can evaluate histological finding precisely, and also we can justify the completeness of resection. So if we can remove it in unblock, so it's a different percentage from ESD and underwater EMR and conventional EMR, but it's balance between your skill and expected unblocked resection rate. So you can choose indication according to that kind of information.
Yeah, very nice, very nicely done.
Thank you.
I think one of the key things of doing underwater EMR is that you must have marking before you actually resect the lesion, isn't it?
For sure, this time I put marking, but this lesion is slightly a little bit elevated, so I think not always definitely necessary. So for this kind of so very flat SSAP or subtle lesion, sometimes it's better to put marking, because in order to check the completeness of resection. Yes. But for such kind of very clearly demarcated elevated lesion, not necessary.
Yep. Why do you choose to close this defect?
For demonstration. Easily, open.
Any question about EMR and ESD with regard to LSD? I'm not sure whether we have the slides on that, but yeah.
So
generally, non-granular LSD, you have to be very careful, especially the pseudo-depressive type. And if the size is more than 2 centimeter, en-bloc resection by EMR will be difficult. So by then, ESD will be needed. So in a center without the ESD expertise, and if we encounter a lesion larger than 2 centimeter, would you suggest we should go straight for surgery?
But maybe piecemeal EMR close.
Still okay, huh? Piecemeal
I think
EMR.
so. And after that, we can evaluate histology, and we can decide. More.
But a lot of times, if we do piecemeal EMR, the assessment of depths, lymphovascular invasions, budding and all that will be difficult. So this is a downside that we should consider if you want to embark on piecemeal EMR.
So theoretically, unblocked resection is much better in terms of histological evaluation and completeness of resection. But it's really, as I mentioned, depend on the available skill and the patient condition. Sometimes surgery is sometimes too much for adenoma, I guess, or intramucosal lesion. So maybe we can. Especially we are encounter high age population. I think in next 10 or 20 years we should consider consider such things, such issues.
So, Prof, in this lesion, just now we suspect is a SSA lesion. So after this, when are you advocate the repeat colonoscopy?
If the histological finding shows a complete resection and adenoma, we usually survey 1 year later. 1 year later.
Okay. Yeah, Professor Wedo is talking about adenoma, not the first SSAP lesion.
Yes, close.
Your surveillance interval should be based on the most serious pathology diagnosis.
So sometimes when we inject the solution in the mucosa, sometimes mucosa is very tense and slippery. But you can see mucosa is very soft and easily capture.
So you have shown two advantages of underwater EMR.
Yes.
First, you mentioned that in your Japan's data, underwater EMR carries a higher en-bloc resection than conventional EMR.
Yes.
Now you show us that because of without the submucosal injection, it is always easier to close a defect.
Yes. Maybe after that I will finish.
You want to switch?
Yes.
Thank you very much,
Thank
Professor
you.
Rudo. That's what that here.
Thank you.
Nice demonstration of underwater
Well done, well
EMR
done.
with clipping.
Fantastic.
Can we switch to room 1 now, whereby I think Professor Uzuka and Professor Ida, they are concluding the case. So over to you, Professor Ida and Professor Uzuka.
Yeah, we.
Thank you.
Yeah, we'll just come out. Yeah, we're coming out. Can we show the old photos? Okay, so essentially, Professor Otsuka has demonstrated very nicely the antegrade single balloon endoscopy. One of the things that I think is a take-home message that we were saying, I don't know whether it was mentioned before, is that I think propofol is, what do you think, Professor Otsuka?
Yeah, propofol is
really
preferable.
Preferable in antegrade single balloon endoscopies because it is a longer procedure, it's a lot more uncomfortable. So I think if anyone wants to do it, they probably should have propofol, otherwise it's quite uncomfortable. The other issue, of course, is, well, these Crohn's strictures are tough. Can you see it on screen?
Yes, we can see.
Yeah, so this woman is an old patient of mine. I inherited from Prof. Go, who's had IBD for the last 8 years or so. And she's quite steroid dependent, so she has flares maybe once, at the most twice a year. She's on methotrexate 20 to 25 milligrams because she had azathioprine-induced pancreatitis. But this is what we see, we're not getting mucosal healing. And this is very, very common, that although a lot of patients are in clinical remission, they are not in endoscopic remission, and they're stricturing quietly, in between. But are you going to upgrade to biologic therapy? So that's a big question in itself. I think I'll have to discuss with her about this because cost is a big issue. It have to be a long-term thing. I think Prof. Atsuka probably will have the same problems in Japan. But what's really good is that you can, with endoscopies, you can really assess the lesion properly to see whether it's fibrous, stenotic, inflammatory, and then after that, base your decisions. Yeah.
And also this stricture has information. So maybe other modalities for kind of, for example, for example, CT or MR, I will be detected. But please, next pictures. And this one. This is also mild strictures, but of course there's some alterations. So maybe a little bit information is there. There is a little bit information, but such subtle information is sometimes difficult to detect other modalities. For example, CT or MRI or a contrast ray. The other way is a CAPS endoscopy. CAPS endoscopy, of course, it can detect this kind of lesions. But if you use CAPS endoscopy, in that case, maybe retention occurs.
Yeah, I would imagine so.
So in that case, I prefer endoscopy.
Yeah, no, we're definitely with our IBD cases using more and more of endoscopy. That's for sure. It's really come into its own, I think. But yeah, okay.
Okay. And so in my hospital, generally, as for assessment of the information, annual MRI. And as for the assessment of the strictures, so first endoscopy when the patient was diagnosed, then every 3 years I and my hospital preferred.
Yeah, that's right. I mean, I think, what does anyone in the audience have any comment, or any of the moderators? Biologic therapy, yes, no, I would say.
Yes.
Ida, can I just ask you, Ida? Ida, you're there?
Yeah,
yes?
yeah.
Ida, she's obviously got multiple strictures, and we're not sure where else she has got the strictures in the small bowel.
Correct.
Just based on that, and with the recent relapse, and given the chronicity of the disease, and so on and so forth, I'm sure we will. We will go with biologics. I mean, I'm all for it. But the issue is, of course, the cost and the duration.
It'll be forever. It'll be forever.
Yes.
That's the problem.
So my question is, if she's been doing all right with methotrexate with no complications, and admissions is just probably once a year, is it all right just to say that's fine and we will go with that?
I mean, this is the million-dollar question when it comes to a country with a limited economy. Sorry, we can't believe what the fake news says. Sorry, I'm kidding. What I mean is, I don't think, that we have unlimited funds. And in our country, I give talks on treat to target all the time. But the problem is, she would have to be on biologics forever. And it seems to be her disease is like this. It's not so bad. She definitely is in clinical remission most times. But obviously, there is slow stricturing. But I keep holding off, for sure. Because every time I mention it, there's always a cost issue, and she's reluctant, and this and that. And again, if somebody's not in clinical remission, it's okay to push biologic therapy. But when someone's in clinical remission, it's very difficult. So that's the dilemma that I have. I think all of us have really in this part of the world, Professor Otsuka. In Japan, of course, you would get biologics.
Yes, but recently Japanese budget is so shrinking. So it's also difficult, very tough question. It's if there's no symptoms, can I use biologics or not? It's very big problem. Yes, same as your country.
Oh, I'm glad. I thought it was just us. Yeah,
Ida, one more. One more question while we are here. What is her further plans for her now, as far as the surveillance is concerned?
Yeah, so this is what I wanted to ask Professor Otsuka, whether or not you biopsy these strictures regularly. Because at this time we did not, because there's also a risk of malignant transformation of these strictures. I've never seen it, but it's been reported in the literature. So I don't know how your IBDologists, do they ask you to to biopsy every stricture?
First, images is very important. If some irregular, it's not a good picture, but if there's an irregular mucosa or irregular villi, in that case, biopsy is preferable because a very small % of the cancer, but the possibility exists. Here today, it's very clear, good villi. So I think it's not malignant. So that's why today I don't do biopsies. And if the other problem is endoscopy is not so easy. So sometimes this inflammatory area causes bleeding. And if late bleeding occurred, in that case, it's very difficult to hemostasis. So that's why I prefer the image diagnosis first. And if there's something unusual, in that case, only I biopsy.
Okay, all right, yeah, thank you very much. Anyone else has any questions? Alex? I don't know where Alex
I was just wondering whether there's any role of surgery if, let's say, biologics is an issue.
But then she would end up with short bowel, wouldn't she? Because she has multiple level strictures. So I wouldn't want to rush in with surgery for her. Even less so than biologics, because exactly. It's tough, it's especially isolated small bowel Crohn's is of course one of the toughest type of Crohn's to manage, because even surgery is not going to be an easy solution. That's the problem.
Profida?
Yeah. Yes.
Profida?
Yeah.
Bring in budesonide. Bring in
budesonide? Well, no, that's budesonide is definitely not the answer in this case. Budesonide has some data for terminal ileal Crohn's, and of course they bring in budesonide MMX for ulcerative colitis as well. I will tell you now that these cases are even more likely to be steroid refractory. As you can see, she's in clinical remission, but the steroid had never induced mucosal healing in her, never. So that's point number one. So if steroids are not going to do it, budesonide is not going to do it. So if anything, if you want to try and give her mucosal healing, you should be upgrading to biologic therapy. Budesonide, I find, is best for steroid-dependent disease, where you want to limit the steroid, the systemic side effects. Having said that, one of my patients is steroid dependent on very high doses. I asked him to change to budesonide, and he told me no, prednisolone is just better. So he's just started himself back on prednisolone. So I'm sorry to say the problem with budesonide is it sounds very good in theory, but in practice it probably doesn't work as well as the traditional corticosteroids. And I think it probably, if anything, is probably limited to very mild sort of cases. I mean, that's my take on it anyway.
And also, the most important point is keeping the remission. So maybe inducing is okay, but as
exactly.
there
has never been
maintenance
evidence.
is the most important problem. So
discussing on the same issue of maintenance, surveillance. Will you do actually fecal cow protecting in this juncture as a correlation to your endoscopic findings and then follow up later? Because endoscopy is going to be invasive most of the time.
That's why only for strictures endoscopy is useful. As for assessment of the information, other modalities such as CT, echo sonography, ultrasonography, or MRI or something is more preferable because much less invasive or almost no invasive.
Yes.
Yeah. So sorry, coming back to the budesonide questions, it is that then, and the other thing is there has been no good data for maintenance. Correct.
Yeah, right.
So but the reality is for the steroid-dependent cases where they are on steroid maintenance, I have tried budesonide, but again, I find it doesn't work so well. But yes, in theory, of course, that's that it does have a role.
Yeah, I agree.
Okay, so thank you very much.
No, I don't have anything to conclude.
Anyway, gradually withdrawing. Okay. Continue. Okay. So rotate and carefully, and now.
Sorry, Prof. Can you show us how you measure the distance when that you have traveled through the intestine?
Yeah.
During your endoscope.
Using the endoscope, so I recorded the chart like this. Can you see? So first marking, I make it. Then I advance I insert the scope, for example, 10 centimeter, 20 centimeters.
Can you focus on the paper?
Huh?
Tell us about the paper. The marking.
Yeah.
The marking paper. Yes.
Yeah. Then second marking with further point from the first marking around 30 centimeter and accumulate. So now 60 centimeter. Then second marking is exist in the 60 centimeter point. Then I further insert the 30 centimeter and I measured by using a scope. And then now 90 centimeter. From 60 centimeter and I inserted more 30 centimeter. It means I reached the 90 centimeter point and repeated as this. So I can measure the length of the small intestine. Generally, total length of the small intestine is around 6 meters or something in ordinary people in Japan. So today, only 160. So only first quarter of the small intestine were examined. But she has other regions, distal side of the small intestine, I'm afraid.
Yeah.
So, do you understand?
Yeah.
Okay. So I can say where is the region is. The location is very important, I think. So to measure, I insist to measure the distance is important. Okay.
Yeah. I think from now onwards we will do it in a systematic way of measuring and then make sure that we don't miss any lesion. And if we found any lesion, we'll document at which length we found the lesion as well.
Yes.
I think this is a very systematic way of doing it. And I think with that, I hope you all agree with us that today we have very interesting cases that we demonstrated in the morning. And then I'll pass the mic to Professor Ida to actually conclude the morning session of live transmission. Over to you, Professor Ida.
Okay, so I think we've come to the end of the workshop, so the live workshop. Does everyone want to come and say hello who's around? No? Okay, I guess it's just us, Alex. And Kihua.
We're wondering where you're serving lunch.
Lunch will be served soon. Okay, Stanley can come. Okay, everyone can join in.
Anyway, Professor Otsuka, thank you very much.
Yes, Professor Otsuka, thank you so much.
As always, yeah. And from all the audience, and on behalf of the moderators, Dr. Rahman, Dr. Ho, Dr. Muru, and Dr. Suresh, we thank the audience.
Yes, thank you so much
and staying on to
to spend some time with us on a Sunday morning.
Yeah.
Okay, so with that, we wrap the session. Thank you to everyone really once again. So let's give ourselves a round of applause.
For the audience, especially the nurses, if you like to visit the unit, it's on 6th floor.
Yes,
You're welcome to go there, and lunch is also served there.
And for those who are involved, the GI motility workshop will be held on the 6th floor in the conference room. Okay, so that's going to be at 2:30. So we hope to see you there.
GI motility workshop is targeted at all consultants and senior GI
Everyone is
fellows,
welcome to come, because I think GI motility is something that a lot of us don't know about. So I think it'd be very useful as for all gastroenterologists actually to learn a little bit more about it. Ruben Wong is going to be our faculty. So thank you so much.
Okay, thank you, and until we see you next year. Take picture, yeah.
Thank you, Ida, and the team.
Also, she has no esophageal cancer.
Yeah, thanks.
Okay, now I finished. Okay, thanks. Thank you very much. Thank you. Thank you very much. All right. Thank you very much. And did you attend the AOCC? Okay. Sorry, not okay. Thank you. So see you again in Shanghai. Yes, of course. Okay. See you. Okay. Thanks.